And certain traumas have greater ability to predict PTSD. What do you think the most toxic event would be if you're going to look at prediction? So you're encountering a patient and you want to try to gauge what they are likely to face down the road, and you're seeing them shortly after their traumatic event. Which events are most toxic?
Man-made events.
So man-made events compared to natural events. And a couple particular man-made events will get you PTSD in the range of 90 to 95% of people exposed to it. What are they?
More.
One aspect of combat. That's one. Another is really important.
Rape.
Sexual assault. That has about a 50% risk rate or quick prevalence of PTSD in the 30 days after. The other is torture. Okay, being tortured will get you 90+% risk of developing PTSD, at least in the short term. The more prolonged and repeated the torture, the greater the risk. There really is a dose-response effect of exposure to trauma. It has been pretty clearly documented across types of trauma. But basically, do we really need a study to say that the more trauma, the worse it is for mental health? Anybody want to, let's debate that. Everybody's quiet.
It's post-dinner.
But it's tricky. And remember, just to put it in kind of a political context as well, this is a very controversial issue. We were talking at dinner just about some of the challenges in sort of the medical legal realm, workman's compensation, disability. Whole set of challenges there. Whole set of challenges in terms of the receptivity of people to the idea of psychological trauma, especially in the absence of physical trauma. People are shunned for displaying PTSD in certain cultures and certain professions. The idea if you have this kind of a reaction, you don't share it with anyone. You keep this to yourself, or you are going to be ostracized by your peers. That still exists. It still exists in a number of different situations, but particularly in professions where you're at high risk for trauma exposure. You see that kind of mindset. You see that kind of a culture, at least in the services I work with.
So, Victor, what is that performance?
We're talking about how, for some people, being under the kind of exposure to threat that PTSD would require enhances some people's performance. They do their best under that kind of pressure. That doesn't mean they won't be symptomatic later, but you can see just that old stress code there. Some people, when the heat is on the most, you see the most adaptive performance.
So that performance is a positive things at a point in time.
Absolutely.
Thank you. Because the other three are pathological in terms of behavior.
Absolutely. And we're going to spend a lot of time talking about dissociation. But, and we call the performance that you see under that kind of condition many things, but heroism is one. People who have that kind of amazing performance we call essentially heroic in a lot of contexts. There's been a newer category of conceptualization of the more immediate reactions to trauma that was really controversial. Acute stress disorder. Why do you think it's controversial? Well, first, what's acute stress disorder?
PTSD symptoms after 4 weeks.
Exactly. PTSD symptoms in the realm of 3 days to 4 weeks with the addition of some dissociative symptoms that are actually not a part of the diagnostic criteria for PTSD. So some acute dissociative symptoms and the three typical clusters of PTSD: hyperarousal, numbing and avoidance, and intrusive recollection. So sort of an amalgam of those symptoms. Why is this controversial to have this be considered a disorder?
It can be part of the normal, I guess, what you call normal response, and subsequently it resolves. I mean, why should it be a disorder?
Absolutely. Absolutely. Amazingly controversial. There are people on both sides of the spectrum. There are people who argue you should provide nothing in the way of treatment other than monitoring until you hit the 3 to 4 week point. There are people who argue that by trying to intervene, you interfere with natural recovery. There are people on the other end of the spectrum that say it's essentially ethically negligent to not intervene if you see the signs and symptoms. So, that means I have to speak a little more quickly than this. And then there's post-traumatic stress disorder. Everyone's familiar with diagnostic criteria and what it looks like. And how many of you have treated PTSD? At least a couple people over there. There are, we could spend the entire evening talking about what aspects of this are debated, but immediate PTSD generally means immediate, soon after the trauma. Delayed PTSD is the more controversial part of this. What is delayed?
You don't have any symptoms for a period of time, and then you get all the symptoms after the trauma.
Does that make sense? What's the, is everybody good with that? What's the period of time it has to be delayed?
6 months?
What's the period of time it could be delayed?
Years.
20 years.
10 years. Decades.
20 years.
There's some prisoner award data in the American Journal of Psychiatry that shows 45, 50 years later symptoms emerge. You see that a lot in the VA system, the Veterans Administration. People are in the hospitals. As they age, what happens?
They get demented.
Yeah. When you get demented, what happens to your ability to essentially suppress the kind of hyperarousal and intrusive recollection of PTSD? I think that's good news. I think getting demented helps. No, it doesn't. It's full, you see wide open PTSD when people lose that frontal lobe functioning. And that's something our VA is really concerned about, because we have a lot of people in that position now from the Vietnam era who are developing dementias and who are you're seeing full-blown PTSD in people who really didn't show it before. That's pretty frightening. To me, that's pretty frightening. Because what it suggests is that there's some way that that constellation of reactions is embedded in biology in a way that it was dormant. And something now, the decrease in inhibition or whatever, has made that active. That's a little frightening. Just like in the same way somebody with a traumatic brain injury can be disinhibited in certain kinds of ways. This is a lot of people comparing this to that, which is here. And then there's chronic PTSD. Generally accepted that about a third of people who develop PTSD go on to have a chronic form. Everybody can agree on what chronic means. Used to be 6 months, now it's 3 months. So then let's talk about a variation that is not a formal diagnosis. Okay, this was a proposed diagnosis for DSM-4, which did not make it in. Made it to the level of field trials. They do have some good field trial data about the construct, but never made it in. Complex PTSD, we're going to walk through this, but what it represents is a series of adaptations, not to a single trauma, but to a traumatic history. Multiple trauma under some unique conditions of subjugation, typically in, think about childhood abuse over a period of time, but also this happens to adults who have been in captivity. And we'll get into that a little bit. And then dissociative disorders. How many of you have treated patients with dissociative disorders? Anybody? How about dissociative identity? Let's go for the goal. How about dissociative identity disorder? Good. Somebody else. But boy, this is going to be really controversial. A lot of people consider the dissociative disorders, with one exception, depersonalization disorder, to be so frequently associated with trauma that they should be included when we talk about a spectrum of reactions to trauma. Okay? Dissociation is fairly well accepted as a corollary of exposure to trauma and a way to adapt and to defend and protect against. The dissociative disorders, more recently, there's been a lot of work looking at the disorganized attachment style. Remember the old attachment styles? I kind of remember them and forget them and remember them. I can't keep them straight. Avoidant, insecure, which is which. Anyway, the disorganized, that's the one I see the most. So disorganized has been associated with the symptomatology of dissociation. We'll say more about that. And then a really interesting literature on the ways people report that they've benefited and grown from their exposure to trauma.